Thank you very much, Dr. Carrico. I know you all are looking forward to lunch, but let's take about 5 minutes for questions for Drs. Grossman and Carrico.
Hello, I'm Arlene Leibowitz from the Department of Public Policy at UCLA and CHIPTS. And I want to thank both presenters for excellent presentations. Cynthia Grossman's detailing of the cascade that has to be accomplished in order to get viral suppression, I think, is really sobering, because there are losses at every stage. And in particular, there are losses when people test positive and not getting them linked to care, which seems particularly a shame, because you have someone in a treatment setting or in a testing setting, and there's this potential to link them to care. And Adam mentioned conditional cash transfers, as did Steve Shoptaw. And that seems to me a really promising intervention. But what I need to know is, how acceptable is that to study sections at NIMH, and particularly how acceptable is it for people who are substance abusers?
That's a really good question. HPTN 065, or TLC Plus, which is test linked to care plus treatment, is a protocol going on currently in the Bronx and in Washington, D.C., and they are looking at a financial incentives piece to link to care from HIV testing sites. And so one of the questions, the reason I think it's a good question is because we're sort of already funding some of this work, at least NIAID is under the HPTN, and we contribute to it. So hopefully they will understand a bit about how acceptable that is. It's a proof of concept, so they're looking at how acceptable it is, also looking at different asking people about different levels. They've set a level for a financial incentive, but really seeing if that's the right level, if that hits the mark. And I think there will be some interesting sub-analyses of that they may be able to pull and understand for those people who have substance use or mental illness, but that may be a little bit harder. That's an interesting question. I don't know if they're specifically looking at how acceptable that would be to certain subsets of the population. They're really looking at it for everybody who comes through the testing site that's either randomized to financial incentives or no financial incentives.
Yeah, I think they're two separable questions. One is how acceptable it is to participants in interventions, and the other is how acceptable is it to NIMH and its study sections? Yeah. Is this looked upon as crass?
So I think that I can't really speak for a study section because, as you may know, the HPTN process for approvals doesn't necessarily go through your traditional NIH study section. But I can say that there was a lot of discussion internally with that particular protocol about the financial incentives piece, a lot of work done to mobilize the community around the incentives piece, because I would say that the question isn't just whether or not study sections find it acceptable, but whether the community also finds it acceptable. And certainly I think there's a mirroring there of what you might find, what the reviewers might find acceptable and what the community might find acceptable. And they were able to move forward with that. So that may set a tone for what's acceptable in the future, but I can't really speak to the study sections for that particular protocol because it didn't go through traditional review study sections.
Yeah, it might be nice to have some kind of a signal in your program announcements about the acceptability. So that would help, I think, researchers.
Thank you. Yes.
I'm Bob Rohr. Trying to get a better handle on how much of the problem is the fragmentation of the U.S. healthcare system and payments and things like that, as opposed to the issues that are associated with particular types of mental health issues. Is there any transnational data looking at other systems and how they handle it, and whether the same issues occur in other national healthcare settings as compared with the United States?
That's an excellent question, and I'm not as familiar with that data as I potentially could be. I will say that within the United States, there are also other models of care. So, for example, if you look across like Kaiser Permanente's data set, both in HIV and I think in mental disorders, they're able to achieve a bit better outcomes in some ways because of the way that they structure some of their healthcare delivery within the context of their private insurance clients. And so I'm sure that there is some comparative data out there, but I'm not as familiar with it as I could be.
Really wonderful presentations by both of you. And I wondered if we could hear your comments about how targeted an HIV testing strategy would need to be for test and treat in the United States. You both presented data, as did Steve Shoptaw this morning, about the narrowness of where the new infections are. But in fact, the National Test and Treat strategy is across the board. And we're investing across the board in a very, very different way. What are the implications of your data for the National Test and Treat strategy?
So I think in terms of the data from the cohorts that I worked with, the implications for test and treat have more bearing on the treat piece. If we're seeing that people are intermittently utilizing ART and discontinuing it at lower CD4 counts, imagine what's going to happen at higher CD4 counts when we start identifying people and immediately treating them when they're not as motivated to maybe improve their own health. So we'll have to get the message out that this does indeed improve your health irrespective of the CD4 count. And the testing piece, my own personal opinion on it, although it's data-free in my instance, is that we need to kind of demedicalize HIV testing and have more kind of expanded access. If we really want to identify new cases, we're going to have to reach those people that aren't testing and accessing clinic-based mobile testing. So we'll have to have consumer-controlled testing. And I'm very interested in the FDA's current entertainment of OraQuick's over-the-counter HIV testing pursuits. And I think that could be what it takes to really transform HIV testing and identify more cases. But there are a slew of ethical issues that come up in having consumer-controlled testing.
I think I would add, I think increasingly, and you've heard it this morning, that we do need to become more targeted in our approaches, and so I think that trend will probably continue. I would just add that, when we talk about treatment as prevention, we have the treatment for those people who are diagnosed and known to be living with HIV and to reach viral suppression, but you also have treatment as prevention in terms of PrEP, and that got a little bit less attention both in my talk and sort of today, and I think when we think about PrEP, I think that's really, we're talking about a targeted approach and a very limited approach, both because of the resources, but potentially also because of the data that we have to support who it might work for. And so I think that with a lot of these approaches, you'll see, I think, a push toward combination approaches, but those combinations of maybe very specialized for particular subsets of the population, at least within the United States.
All right, thank you, everyone.
Thank you very much to all our morning speakers. It's now about 10 after 12. I have a couple announcements. One is someone gave their room key to a security guard to open something, and he didn't remember who it was or what, but if it was one of you, here's your room key. It doesn't have a number on it, so you can see me for that. The other thing is that we'd really like you to consider using the video blog, which is downstairs at the foot of the escalator, and if you'd be willing to talk for just a moment about what treatment as prevention can mean for you on any level that you choose to talk about that, we'd be really happy, because we'd like to get those posted onto our website in the next couple of days. And I'd ask that any of the speakers in particular avail themselves of the draped off room at the foot of the escalator where you'll be asked a couple simple questions. So we have a box lunch today. You can see it's all along the back there. There are 4 different kinds of sandwiches, including a vegetarian option. There's sodas, all sorts of things back there. As I said, it's a little bit past 10 after 12. We're going to reconvene at 1 o'clock to talk about the AIDS Drug Assistance Program, and then to hear from Dr. Carl Diefenbach later this afternoon. So we've got until 1 o'clock. You're welcome to take those lunches, bring them back to your tables here, go to any of the seating areas that are down on the lower floors here, whatever works for you, but to please be back at 1 o'clock. Thank you very much. And here's your room key.